gases. And what I don't have on there, I want you to know that the PaO2, when you look at a patient that has anemic hypoxic, we know they've been in a house fire or exposed to carbon monoxide poisoning, their PO2 is going to be a false reading. It's not going to be accurate. It's going to be very, very high. But the pressure that we'll assess will really truly not be oxygen. It'll be from the carbon monoxide attached to the hemoglobin. So the PO2 is going to give us a very high false reading. It's not accurate. And then the saturation will probably be 100%, but that's not accurate. So we understand as respiratory therapists that when a person comes in the emergency department and they have singed nasal hairs, vibrissae, immediately suspect carbon monoxide poisoning. When you can smell it, or if they're unconscious, they can tell you. They have the red, very red cheeks. The face may be red, the hands are flushed, the toes are flushed. They are cyanotic. PO2 is inaccurate, saturation is accurate. So what we're reading, a PO2 300, 400, is really not PO2, it's carbon monoxide. Okay? So I'm saying that so you don't see a PO2 in the 300, 400s and think that the patient doesn't need oxygen. They do. They need 100% oxygen. So in this case, your PO2 and your pulse ox is inaccurate and will give you a false reading. Yes?
In the reading, they said for people with CO2, when they're talking about the pulse meter, and they used another tool, and I'm drawing a blank what it was. They said it was like a trans something, and what we never talked.
Repeat.
They were saying, and actually it was in our lab book, but they were saying they were checking for something with CO2 poisoning that you should
carbon monoxide.
Carbon monoxide poisoning. They're saying use the pulse ox meter, and then they said another device.
Coaximeter.
Yeah, it was trans. That means you have they said trans oximeter or something like that. Is that similar to the pulse ox?
No, that's a blood gas machine.
It's a blood gas. Okay, because they didn't really say what it was. They just named the term.
Yeah,
I didn't have time to look at it.
I'll tell you.
Okay,
yeah, we'll use it. There's blood gases, and a blood gas that, well, you asked, okay, the blood gas machine that just measures functional hemoglobin is called oximetry, and it's a blood gas machine, and we run our blood gas through it. But a lot of places now, most hospitals now have what we call co-oximeters, and the CO is carbon monoxide. So a co-oximeter measures dysfunctional hemoglobin. So it can give us that carbon monoxide level, carboxyhemoglobin. It not only will it give us the blood gas reading, but the PO2 and the SAT are still off, excessively high. It will give us the amount of carbon monoxide that's in the patient's blood, whereas a co-oximeter won't. Okay, so we have older blood gas machines that only measured functional hemoglobin, meaning the hemoglobin that's saturated with oxygen. But now we have newer co-oximeters that can measure sickle cell hemoglobin, carboxyhemoglobin, methemoglobin, fetal hemoglobin. Compared to us, those are all dysfunctional. So it's called co-oximeter. Oximetry, something that measures oxygen, which would be your standard ABG. But most departments that have blood gas machines now have co-oximetry. And this measures functional hemoglobin as well as dysfunctional. And carboxyhemoglobin is dysfunctional. So that's what Roy was referring to.
So carboxyhemoglobin is the hemoglobin that's got carbon monoxide attached to it, right?
Yes, that's what that CO is for. Yeah, carboxyhemoglobin. So that's called co-oximetry or co-oximeter, and it measures dysfunctional hemoglobin. So it'll measure carboxyhemoglobin, it'll measure methemoglobin, it'll measure fetal hemoglobin, and other hemoglobin. Sickle cell hemoglobin compared to adults, these are all dysfunctional. Okay, so we have oximeters and co-oximeters. So if, I'm not saying that a person with anemic hypoxia, you can't run their blood gas through an oximeter. You can, but it's not going to give you the amount of carboxyhemoglobin in the patient's system. If we want to know how much of the carbon monoxide is in the individual's blood, then we need to run that same blood gas through a co-oximeter. And it'll give us not only the dysfunctional, but the functional. And the PO2, regardless of whether oximeter or co-oximeter is off, it's false. It's going to be relatively high. It'll be in the 300, 400s. We are not deceived. We know the patient still needs 100% oxygen, right? Everybody understand that? The saturation will probably read 99 to 100%. It is off. It is not saturated with oxygen. It is saturated, the hemoglobin is saturated with carbon monoxide. So they still need 100% oxygen. Okay? Any questions with that? Yes?
Yeah, really question. So basically, even though if we don't do any of the readings from the machine, we're going to notice the red face.
Yeah, if a patient's been involved in a patient's been involved in a house fire, you'll smell it.
Okay.
If it's been a carbon monoxide poisoning, either the E-Techs or somebody will let you know. The physician may have to let you know. Yeah, and you know 100% oxygen.
Right away.
More than likely, they'll need to be intubated and placed on mechanical ventilation at 100%. But nevertheless, you may have somebody just come in that's talking with sage or singed rather nasal hairs. That means we need to do something protectively. Because if not, later on down the line and within 8 hours, they could be in trouble. Okay, now what we need to do, I'm not going to talk about that now, but blood gases can be deceiving in this area. So if you see a PO2 300, 400, you see a SAT 100%, but we run the blood gas through co-oximeter and the met hemoglobin, I don't care if it's 5 or 6 or 12%, they need 100% oxygen. Okay, or the carboxyhemoglobin, we'll know. And then anemic hypoxia also can be a deficit in red blood cells, which has nothing to do with carbon monoxide poisoning, but it takes longer because remember, the PO2 reflects external respiration, right? Mm-hmm. And the SAT reflects hemoglobin saturation. And hemoglobin carries 98% of oxygen. So if it's a deficit in red blood cells, it's going to take a little while for a patient to experience the hypoxemia. But it could happen. And so patients with sickle cell, you'll have them frequently, and they ache all the time. Their joints ache. And their joints ache because they have a deficit of red blood cells, and then the red blood cells that they have are shaped abnormal. So they hurt all the time. They're always in chronic pain. And so giving them oxygen may help, but it's not going to correct the abnormality. Does that make sense? It doesn't help it. Okay, any questions about hypoxic hypoxia or anemic hypoxia? Okay. Letter C, circulatory hypoxia. It's nothing wrong with the external respiration. It's due to low blood pressure, decreased cardiac output. External respiration has been fine, but let's say a person is bleeding. Maybe a person was in a car accident or an injury at work, and they're bleeding out. Well, it's the responsibility of the cardiac output and the blood to get the arterial blood to the oxygen, to the tissues, right? Mm-hmm. Well, if the blood pressure is low, so hypotension can cause circulatory hypoxia. Or let's say someone's bradycardic. We know normal heart rate is 60 to 80, right? Patient comes in with a heart rate of 35. They're going to eventually experience circulatory hypoxia. Nothing's wrong between gas exchange between the lungs and the atmosphere. The problem is internal respiration. The blood pressure is so low, the blood is not, the pressure of the blood being perfused to the tissues is inadequate. So circulatory hypoxemia can reflect the heart itself or cardiac output. We're concerned about that cardiac output. And or it can be blood pressure, low blood pressure. Another name for hypotension, because it could be a fluid deficit, is hypovolemia. 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 That's another name for low blood pressure. So a patient could be hypovolemic. They're bleeding internally. They're bleeding out because they were in a car accident or some kind of injury. Or it could be a direct effect for the cardiac output. So if there's a decrease in cardiac output, what kind of drug would you recommend?
Inotropic.
There you go, beta 1, positive inotropic drug. We don't administer it, but we know. Now, we can give 100% oxygen till the cows come home. That's not going to correct the problem. The patient needs a pharmacological intervention, and it's beta 1, positive inotropic drug. See why I teach you what I teach you? Okay. So oxygen is going to only support this type of hypoxia. It's not going to correct it. Got it? And mind you, I got CO over here. This CO is carbon monoxide. C period, O period is cardiac output. Got that? TB together is tuberculosis. T/B is tracheobronchial tree. Got it? All right. Then the last kind is called dysoxia. I don't know if your book says dysoxia or it may say histotoxic. Histo, Histoxic. Histotoxic. And another name is dysoxia. That's what I have up here. Okay, what is that? It says disruption and inability of the cells to utilize oxygen during internal respiration. So this doesn't have anything to do with the lungs. It could be like, let's say a child gets hold to some antifreeze, Lord forbid, or some window washer solvent, or some kind of poison. So this type of hypoxia is nothing wrong with internal respiration. But because an individual has ingested poison, at the point of internal respiration, the poison will not allow the oxygen to go across into the cells. And that's called dysoxia. So this doesn't have anything to do with external respiration. Has anybody ever heard of Clostridium tetani? Anybody heard of that?
No.
Has anybody ever taken a tetanus shot?
Yes.
Sure you have. It's caused by the pathogen Clostridium tetani. What happens, it causes lockjaw. And when it causes lockjaw, that pathogen releases a waste. And the lockjaw itself locks the jaws, and then it will paralyze the diaphragm. But the waste that the bacteria releases, it too causes dysoxia. So there's nothing wrong with external respiration. So for a while, if we have a patient like this, we'll look at the PO2, it's fine. But we remember that only 2% of oxygen is carried that way. That's minuscule. It's going to interfere with internal respiration or oxyhemoglobin, which 98% is carried that way. So you see why we have to look at things 2 and 3 dimensional? Okay. So a physician may not identify, particularly if they don't know, they may not be able to identify the hypoxemia or the hypoxia, but you should be able to. And then not to say that we don't administer oxygen, but oxygen cannot correct all of these. Oxygen hopefully can correct 1A. It cannot correct 1B. It cannot correct 1C. And it cannot correct 1D. Can't. It's supportive. Does that make sense? Does everybody see why I said what I said? So oxygen is not the wonder drug. It's supportive, but it cannot correct B, C, and D. Underlying cause has to be treated. Make sense? All right. So those are overall the 3 indications for O2 therapy. So hypoxia, the patient's not receiving an adequate amount of oxygen while breathing. You and I, or an asthmatic, we can get pneumonia. We would experience hypoxemia because we have pneumonia. We need oxygen. Oxygen doesn't resolve the pneumonia, but oxygen will take care of our oxygen deficit. Once the pneumonia is resolved, then we will go back to breathing off room air and we're fine. Okay? However, patients who have chronic conditions may never, ever get back to what we call normal. So they're patients that you're going to deal with, write this term down, that are chronically hypoxemic. Chronically hypoxemic. Chronically hypoxemic. And Rachel, what does chronic mean?
It means over 90 days.
Right. So I've never discussed it, but COPD patients, chronic obstructive disease patients, they're always going to be chronically hypoxemic. It doesn't matter what we do for them, because there's been some damage to the lungs. Does that make sense? Any questions with that? And I'll explain that a little bit more as we go on. But oxygen is a drug, but it is not the answer to every problem. In many cases, it's only supportive. Okay? And to give you a very extreme, someone has cancer of the lung. We give them oxygen, they still have cancer. We don't deprive them of the oxygen, but the oxygen is only palliative. It's only supportive. Does that make sense? All right. Any questions? 1, 2, or 3? 1A, 1B? Yes, sir.
You mentioned sickle cell. My understanding of sickle cell was that the RBC assumes the shape of a sickle, therefore it can't diffuse through the tissue. Mm-hmm. How does oxygen help sickle cell?
It helps, but it doesn't help because they have these sickle cells, so their hemoglobin capacity is greatly decreased, and that's why they're always in pain. Then they're also at a greater risk for stroke because the sickle cells would aggregate, clump together, and possibly travel to the brain, and then they can have a stroke. So it's an abnormality that oxygen cannot correct.
But you would give somebody suffering from sickle cell oxygen?
If they need it.
Okay.
Yeah, but that's not always the crisis. I mean, that's not always the answer. But yeah, sometimes you will have patients, and it's just palliative. It's just supportive at that point. It's not going to correct the problem.
Okay.
All right. You could have somebody, another example of anemic hypoxic. You could have, let's say, let's say someone has internal bleeding, and they don't know, they've been a little sick, but they didn't know they had internal bleeding, and they come in, and red blood cells, what value did I tell you they are?
98%.
Red blood cells, 4 to 6.
4 to 6.
Let's say they come in and their red blood cells are 2.5. Well, right now, if their red blood cells are 2.5, I don't even need to know what the hemoglobin is, because I know if the red blood cells are decreased, the hemoglobin is decreased, right? They need oxygen. But in this case, we're going to give them oxygen, but that's not just the answer. They don't need whole blood, because whole blood contains the 5 type of white blood cells as well, right?
Right.
All they need is packed red blood cells. So they may be given packed red blood cells, and we're going to administer oxygen to them as well, because they've experienced anemic hypoxia. So in that case, again, oxygen is not the answer, but it's supportive. So anemic hypoxic can be a patient needs packed red blood cells. It could be that they have some type of other type of anemia, or it could be that they've been exposed to carbon monoxide poisoning. And in the carbon monoxide poisoning, you know you have a false PaO2 reading, you have a false saturation reading, and you provide 100% oxygen. And you need to run your blood gases, well, I say you, whomever's running the blood gases, through co-oximetry. And so what is co-oximetry? That's a blood gas machine that analyzes functional and dysfunctional hemoglobin. Yes.
So who will give them those packed red blood cells? We have the respiratory
No,
care, but the
no, physician. Physician will order, nurse would administer.
Okay,
Yeah.
so while the nurses administer that, we'll still be there get providing oxygen to the patient?
Yes,
Okay.
yes. And even after they've been given the red blood cell, the packed red blood cells, we'll probably still keep them on oxygen for the next 24, 48 hours. Yeah, yeah. We want to continue to monitor. We may not do a PaO2 because we don't want to disrupt that red blood, those red blood cells perfusing, but we certainly want to monitor their pulse ox and see how they're doing. Yeah. Okay. So what's my point? Everybody that you'll give oxygen to, their primary problem won't be respiratory. And that's why we have to understand, and that's why you guys are sitting here. You're going to have many patients. Probably, I don't know, I better not put statistics with it, but I want to say probably up to 60% of the patients that you deal with, their primary problem won't be respiratory. It will not be. It'll be other problems that are going to affect the lungs or affect oxygenation. Make sense? Okay, any questions with this? All right, yes.
Now, in regards to those indications for O2 therapy, we have a patient that comes in and we see, well, you can't just see that as an indication, but let's say a patient has increased work of breathing, and we need to determine if that patient is hypoxic. Should we do the co-oximetry first, or it depends on under what circumstances the patient was brought in?
It depends on patient assessment and the circumstances.
Okay.
The co-oximetry is a blood gas. You don't necessarily need a blood gas to give patient oxygen. Okay? You don't. Okay? Because if we give other than a COPD, I'm not speaking of COPD, they're in a world of their own. If you give a patient oxygen, they should respond to it less than 2 minutes.
Okay.
Okay?
So once we give that patient oxygen, and that patient responds to the oxygen, and we may have to use the co-oximetry or the oximetry, should we use the co-oximetry first to see?
Well, it really depends on what your department has. If your department doesn't have co-oximetry, you can't run it. It's a piece of equipment. It's a blood gas machine. But most probably will have it now. Most probably will. Yeah, they probably will. If you don't have it, you can't use it. Yeah. And you may be involved in doing the ABG puncture. It depends on where you work. Some departments in respiratory care don't do ABG punctures at all, but we're responsible for running the blood gas machine. Whether you do the puncture or run the blood gas, you're still responsible for interpretation. So it doesn't matter which end you're on, you still should know. Okay, just like PFTs. You may be in a department they don't do PFTs, but nevertheless you're still responsible for being able to interpret or understanding the physician's diagnosis. Does that make sense? All right. Okay, any other questions? And I'm gonna, as time goes on, I'll begin to give you scenarios and relate this so it'll make sense to you. Okay, assessing the need for O2 therapy. This is somewhat what Ebony was asking me, lab work. You want to know, you may not get it immediately, but somewhere down the line, what are the patient's red blood cells? Why do we want to know that? Are we dealing with anemic hypoxemia? What's the patient's hemoglobin? What's the patient's hematocrit? Did I tell you about hematocrit?
No.
You all had A and P. Anybody remember what hematocrit is? It's the percentage of red blood cells in the whole blood. Percentage of red blood cells in the whole blood. That's hematocrit, HCT. Percentage of red blood cells in the whole blood.
What was the abbreviation?
There it is on your phone. HCT, hematocrit. So we need to know what red blood cells are. We know that's 4 to 6 because in the red blood cells are hemoglobin, right? And I gave you, but for right now, let's just say hemoglobin, a good hemoglobin is 15. It's a little lower for women and a little higher for men, but for right now, we're just going to use a perfect 15. And then hematocrit, that's the percentage of red blood cells in whole blood. For women, it's about 42%. And for men, it's about 45%. So we use a range. What? 42 to 45%. Make sense? Mm-hmm. All right. That's where we get the numbers from. All right. Now, if a person's anemic, guess what? Red blood cells will be decreased. If red blood cells are decreased, then what? Hemoglobin is decreased. You know immediately your patient is dealing with anemic hypoxemia, right? All right. And then hematocrit will be decreased because hematocrit is the percentage of red blood cells in the whole blood. So whether you see hematocrit or hemoglobin, so we know hematocrit, you just learned, is 42 to 45%, right?
Yes.
All right. If I tell you a patient's hematocrit is 36% and ask you, is the patient experiencing hypoxemia? Yeah. How do you know? Because the hematocrit is less than normal. And hematocrit represents the percentage of red blood cells in whole blood. Make sense? So we can look at these values and make a call. If it's anemic hypoxemia, do we run these? Do we ascertain this information? No, we don't. But once the data is available, you can take a look at it and make a call. Any questions? All right. Now, these values can be normal, and the patient just so happen is experiencing another type of hypoxemia. Got that? Yes, ma'am.
Now the lab work, is that going to be pretty much standard every patient that comes in? Is that
Depending
like
on what's
that?
going on. But CBCs are standard.
Okay.
Complete blood count,
Okay.
that's pretty much standard. Pretty much standard. Somewhere down the line. It may not be done initially, but somewhere down the line it's pretty much standard. Yeah. Okay? Any questions with that? So red blood cells 4 to 6. And I'm going to show you a trick. And some of you are just going to freak out, and I don't care. Just freak out and come on back. This is how you keep this stuff in your head. It may work for you. It works for me. Let me put it this way. You don't have to memorize it this way, but this is how I keep these numbers straight in my head. If it works for you, good. If it doesn't, don't write it down. I know that Henry's law of solubility coefficient is a very, very small number. So I know it's 0.003. I know the E-tank factor is 0.3. I know the H-tank factor is 3. Yes?
Yes.
All right. Now, I'm looking at red blood cells. Red blood cells is 4 to 6. So the perfect number is 5. And then I take this 3 and I multiply it by 5 and I get 15. There's my hemoglobin. And I take 3 again and I multiply it by 5 and there's my hematocrit. That's how I keep this in my head. Now if this works for you, fine. If it don't do it. You figure it out any other kind of way. This is how I keep numbers straight in my head. This is how I always know the ballpark of what is normal. And then, I don't know if I gave you the values for cardiac output. Cardiac output is 4 to 8. I put cardiac output 5. And I stay in the ballpark. This is liters per minute. This is how I keep these numbers straight in my head. Now again, it's not mandatory. This is just Kathy Miller. Like Charles looks at TV and Gay Lussac lives in a TP. That's Kathy Miller. You're not going to find this in the text. But this is how I keep these straight. So if this works for you, fine. If it doesn't, find something that does, because you need to know it. Okay? Any questions? That's how I keep all these numbers straight in my head. Now, once you write them down, you need to know what they are. All right, so assessing the need of oxygen, we look at lab work. That would be a CBC. It could be under hematology, a CBC's complete blood count. And we want to look at that. There's other parts to it, but this is in reference for oxygenation. Okay, your condition, what Ebony was asking me, can be based on a specific clinical problem or diagnosis. We know what the diagnosis is. Now, we haven't gone into pathophysiology other than you learned about asthma and mast cell degranulation. But observe the patient, examine the patient. Signs are objective data. So you can go to the patient's chart in hematology and find the lab work. That's objective data that you can see. You can look at the patient and see that they have an increased work of breathing, or they're using their accessory muscles, or if they're cyanotic, you can see it. So that would be objective data or signs. Any questions with that? So not only we're going to depend upon lab work, we're going to use our eyes as skill assessment and assess the patient. And then you can ask the patient if they're able to tell you, and that would be a symptom or subjective data. And remember, if a patient is comatose or confused or in a coma, you have no subjective data. Their family may say something, but you can't say patient stated. You have to indicate wife stated or family, adult, whomever stated. That didn't come from the patient. And so together, signs and symptoms or objective and subjective data are clinical manifestations. What is the patient presenting? How is the patient presenting? What is the patient saying? We never disregard that. And I'm telling you guys, don't be intimidated, but your asthmatics will know more than you. They should, because they've been taught correctly. And asthmatics should know where they stand during an asthmatic attack. And an asthmatic should be able to tell you what they got a hold to. Once in a while they may not know. But don't be intimidated by your asthmatic patients or your COPD patients, because they should be knowledgeable of their condition, and they will tell you, I don't do too well with terbutaline. Wonder how they know that? Because they tried it and it didn't work. If I have to go in the hospital now, I said, no, I don't want albuterol. It doesn't work for me anymore. I was on albuterol for about 15 years. Now I need lev-albuterol. Bring me some Zopanex. Okay? All right. Now, here we go. Remember, I'm saying remember. I haven't gotten it here. I think I put it there so Kathy would remember. If the PaO2 is less than 60, then a patient is breathing off his or her hypoxic drive. And here we go. I'm going to explain what a hypoxic drive is. And the next bullet says explanation of central chemoreceptors and peripheral chemoreceptors. So let's talk about a hypoxic drive. Obviously, if you see that word hypoxic, what does that mean? PO2 less than normal, right? All right. All right. However, we've talked about ventilation is inhaling oxygen and exhaling CO2, right? Most people think, this is why you're in a classroom with me, most people think that our stimulus to breathe is based off a need for oxygen. It is not. Our stimulus to breathe is based off how much CO2 our body produces. So our ventilatory drive is based off CO2, not how much oxygen we need. It's based off CO2 and how much we exhale. And that's why we're concerned about hyperventilation and hypoventilation. That's what stimulates for us to breathe. Carbon dioxide, not oxygen. The need for oxygen does not stimulate us to breathe. It's our body's ability to produce CO2. Any questions with that? Where does that CO2 come from? It's a waste product. Where does it come from? From the tissues. At cellular level, right? Let's go back to cellular level. Oxygen goes in the tissues, vitamins, nutrients, the good stuff, right? And they get in the tissues and they produce energy to make us feel good, right? And so as a result, the waste product, carbon dioxide, is produced. Make sense? And that's called internal respiration. And back here on the slide prior to, I have, it's also called cellular metabolism. So another name for internal respiration is cellular metabolism. I'm going very slow so you can understand this. So we look at ventilation, the function of the lungs. The first part of ventilation sounds crazy, but I'm going to put it in this order, but it's really not the correct order. We inhale oxygen, yes? Mm-hmm. When we inhale oxygen, that's the first part of ventilation. In between ventilation is external respiration, gas exchange, yes? Yes. And after that gas exchange occurs, CO2 comes out of the capillaries and goes into the alveoli, yes? Yes. And then the second part of the second part of ventilation, we exhale the CO2. Now we understand the CO2 came from the cells and it's a waste product. It's acid and it has to be exhaled. Yes? Yes. All right. So internal respiration we also call cellular metabolism. Oxygen, sugar, vitamins, nutrients, all the healthy stuff, electrolytes go inside the cell and they get together and party and rumble, and you feel good, and then they produce CO2. Well, CO2 has got to get out of the body, and we know two ways it gets out. Through the lungs in the form of CO2, and through the kidneys in the form of urine. Yeah?
Yes.
Any questions with that? All right. Now, back to the lungs. This is why our breathing drive is not based on how much oxygen we need. How well we ventilate is based on how much CO2 our body produces from cellular metabolism. That's what stimulates us to breathe. Isn't that weird? But it is so. All right. So what we have in our brain, that same respiratory center when I talked about the parasympathetic and the sympathetic and the 10th cranial nerve and cardio accelerator and cardio inhibitor and all that good stuff, right up there in that same respiratory center, the medulla oblongata anatomically, and then the respiratory center physiologically, are what we call central chemoreceptors. And remember on the sheet in pharmacology, I said I had two on there I hadn't explained, but you all figured out what they were? Central chemoreceptors. I'm going to erase this. You can look in your cardiopulmonary alien book, and there it is, chapter 9, and you'll see, and it's in Egan's too. Central chemoreceptors. Central. Meaning right up there in that medulla oblongata. Central chemoreceptors, they're receptors. They're the ones responsible for determining whether you're eucapnic, and what does that mean? Breathe normal. Whether you hypoventilate, retain CO2, or whether you hyperventilate and blow off CO2. I'll give you time to write that. Central chemoreceptors are responsible for how well you ventilate. Any questions with that? I know you're still writing, but I want you to absorb this. Central chemoreceptors will determine how well you ventilate. And what are they?
Chemical receptors.
They are, what is it? The hydrogen ion. It's the hydrogen ion. I'm going to lift this up now. So up in your brain, there's hydrogen ion. And what do you know the function of the hydrogen ion? What else does the hydrogen ion do? Determines your pH. The hydrogen ion determines whether your blood is acid or base, right? Same hydrogen ion. So can you see how that hydrogen ion ties into how well you breathe? Because that same hydrogen ion is saying this condition is respiratory acidosis, this condition is respiratory alkalosis, and we haven't talked about, well, we did talk about it a little, compensation. If we have a metabolic condition, then the lungs will respond, raising the pH or lowering the pH for it to become normal. Right? So this same hydrogen ion that determines your acid-base balance is the same hydrogen ion in your brain determining how well you ventilate. And it's called central chemoreceptors. So the central chemoreceptors will determine if you blow off CO2 or retain CO2 based on the hydrogen ion activity. Okay? So this is in one of the sheets that I gave you for blood gases, but I've got to go through this so it'll make sense. Yeah.
I just want to make sure, this is how I heard you. The chemoreceptors respond, they base their responses on hydrogen ions. Are you saying it's based on the level of hydrogen ions within the?
Yeah. Okay. Within the blood-brain barrier,
Within the blood being, okay, thank you.
We turn it off at
the blue spot, yeah,
that one.
yeah. Hit it again. Maybe that's not the right
You want
one.
to jump on my shoulders?
No, it's not that one, it's
This one
this
here?
one, yeah. There, hit it again. Thank you. All right. Okay, let's look at this. The handout that I gave you, it's got probably on the second page. Everybody see the hydration equation? Look on that ABG handout. I gotta tie this in. Here's a stud somebody perhaps lost. If you don't have a handout, fine, just write this down. This is called the hydration equation. You all, if you have it, fine. If not, write it down. It's called the hydration equation. Is it on there? I didn't see it.
I don't see it.
Okay, so I haven't given you all the, okay, I'll make sure that I bring it. If I can pull it out tomorrow, I'll bring it tomorrow, definitely Wednesday. Okay, all of this is acid-base balance and all of this is ventilation. Here we go. CO2, where is CO2? In our lungs. We exhale it. Okay, where does water come from? What's the responsibility of the nose? Humidify, right? So this comes from the water because when the dry air gets to our lungs, it needs to be saturated with water, humidity, right?
Yeah.
So this is the water in our lungs, and it's the function of the nose and the carina to take care of that, yes?
Yeah.
All right. Over here, this is the kidneys. And we call it what? From an acid-base perspective.
Metabolic.
Metabolic. And we over here, we call this what? Respiratory.
Sorry.
All right. Any questions with CO2, water, and bicarb?
No.
Okay. During internal respiration or cellular metabolism, an acid is produced. And this is called carbonic acid. Carbonic acid. See the carb in it? Anything with carbo or carbonic means it's got a carbon atom in it. This is what really is produced in our body, carbonic acid. But carbonic acid has the ability to change forms. Okay? It's H2CO3. So let's look at this. When it goes to the lungs, see the two H's? All right. See 3 oxygens over here? There's 1, 2, 3 there. See it? All right. You see the 1 atom of carbon? There's the 1 atom of carbon here. See it?
Yes.
So, this carbonic acid that's produced as a result of cellular metabolism, it comes out, and thus far, I said in the form of CO2, right? I said that. But it really comes out as carbonic acid. When it goes to the lungs, it converts and breaks down to a gas called CO2, and then the water remains in our lungs, saturating all the air. All right? So, my name is Kathy Miller. In class, you know me as Miss Miller. When I go home and I'm with my granddaughter, she calls me Abuela. When I'm in church, I'm Pastor Kathy. I'm all the same person, but it depends on where I am, how I'm addressed. Got it? So this is cellular metabolism. This is how CO2 gets out of the cells in this form. But when it goes to the lungs, it converts into a gas, and we exhale CO2. And this is what stimulates our breathing, and then the water saturates our lungs because we understand when we inhale the dry gas. Yes? When it goes to the kidneys, and it produces urine, we look at it in the form, here's one hydrogen, and here's one hydrogen here. See the two hydrogens? There's the one carbon here and the one carbon here. See it? There's 3 oxygens here and 3 oxygens there. So when it goes to the kidneys, it becomes bicarb. Okay? And then now this is a free-floating hydrogen ion. Number 1, you've learned that it determines your acid-base balance, right?
Yes.
And this free-floating hydrogen ion floats in the blood, goes up in the brain, and it goes across the central chemoreceptors. And the central chemoreceptors will then determine how well you ventilate.
That's pretty cool.
That's it.
Really is.
And you need to understand this. This is called the hydrogen equation. So this little fella is a free-floating. And so what am I saying? In the kidneys, call me bicarb. In the blood, call me carbonic acid. In the lungs, I'm CO2. But I'm really hydrogen ion regulating the whole shot. So it's based on where I am, how you address me. But I am who I am. That's what hydrogen ions say. Make sense? And so that's why central chemoreceptors control how well you ventilate. Why? Because it's hydrogen ion telling CO2 what to do, telling the lungs how well to ventilate. So our ventilatory drive is based upon CO2, or our breathing drive is based upon CO2, not how much oxygen we need. Any questions? And this has to do with how well we breathe. And now you can see when we talk about acid-base balance, we're looking at respiratory and we're looking at metabolic. Okay? CO2 and bicarb is the same waste product. It's just when it goes to the kidneys, it's identified as bicarb. When it goes to the lungs, it changes form. It's no longer a liquid. It's a gas, and it's identified as CO2. But up in the brain is hydrogen ion, one little ion making the call for how well these ventilate. Hydrogen ion makes the call for this and makes the call for that. And so that's the whole ideal of a compensated blood gas. Why? Because of the activity of that hydrogen ion. Yes.
There has to be a medical condition then, if the chemoreceptors aren't reading that hydrogen output, then it would screw up the whole system. It wouldn't work.
COPD.
That's COPD?
We'll get, yeah, that's one. We'll get there. Okay? Any questions? Everybody understand this? I know you have to write it down. You can look in I don't know if it's in Egan's. I do read Egan's, but I read Egan's specifically. But look in cardiopulmonary A&P, chapter 9, control of ventilation. What controls ventilation? That hydrogen ion, central chemoreceptor. That's what controls ventilation. It is in chapter 9. I will give you another handout. I thought I had given you 2 handouts on blood gases, but I apologize, I hadn't. I guess I was moving slow. So this is carbonic acid. It's volatile. It means that it can break and change forms. You don't allow your children to call you by your first name, do you? Okay, that's what it doesn't mean. When I'm in the lungs, you address me as carbon dioxide, and I am a gas. When I'm in the kidneys, you address me as bicarb, and I'm a fixed urine. I'm a fixed liquid, excreted as a urine. And this free-floating hydrogen ion determines everything. This little fella here. So that's why compensation in a blood gas is so important. And this makes the call for all of it. So central chemoreceptors are controlled by the hydrogen ion moving and vacillating across the brain barrier. Where did the hydrogen ion come from? From there, from this formula. Continuously blood flowing, continuous internal, external respiration. That's where it came from. And this is the waste product. It's got to get out. How does it get out? Through the lungs in the form of CO2 and through the kidneys in the form of bicarb. Who or what is determining it? Hydrogen ion. So our ventilatory drive is based upon CO2, not a need for oxygen. And what's determining it? Central chemoreceptors located in the medulla oblongata, telling or continuously sending messages via the 10th cranial nerve, via acetylcholine, how well to ventilate. Any questions? All right, that's central chemoreceptors. Okay, Kathy, back to the hypoxic drive. Well, what happens? As long as our PO2 is 61 or higher, we breathe off our central chemoreceptors. And that's normal. We should. Central chemoreceptors. PO2, 61 or higher. And I'm expecting you all to know this. Therapists know this. Everything I tell you, I expect you. Eventually, you'll get it. All right. Now, let's say we have a patient who, I don't want to use the asthmatic. Let's say we have a patient that has pneumonia. Does anybody in general know what pneumonia is? Just in general.
Infection in the lungs, right?
Infection in the lungs. We've learned through all our defense mechanisms the lower airway is sterile, right? The only thing that should be moving through your lungs is oxygen and carbon dioxide, and it's a sterile field, humidified, yes? But if a person gets an infection in the lungs, they begin to get consolidation or buildup of fluid. And with that buildup of fluid, everybody understand it's a buildup of fluid. It's like water and syrup. Which is thicker? Syrup. Okay. It's like gas trying to diffuse carbon dioxide and oxygen go through that syrup. And it's not going to do too well, is it? Everybody with me? So then if we do a blood gas, we're going to see that PO2 probably drop less than 60. Okay? PO2 is dropped to less than 60. Anytime a patient, don't care what kind of patient it is, any kind of patient where their PO2, not hemoglobin saturation, I'm just talking about PO2, anytime a patient's PaO2 drops below 60, central chemoreceptors will shut down. They'll stop. Like, oh, this is not my responsibility. There's another need here. Central chemoreceptors shut down at a PO2 of what? 60 millimeters of mercury or less. And I know all of this is not in the PowerPoint. I'd probably have 100 slides trying to explain it. And I wasn't doing it. Okay, so we got it now. PO2 is now 60 or less. It could be 58, 48, whatever. Central chemoreceptors shut down. They automatically shut down. So Kyle is looking at me, then what? Well, when the central chemoreceptors shut down, we have another set, a backup set. And it's called the peripheral chemoreceptors. Peripheral. When are they activated?
CO2, 60 or less.
PaO2, 60 torr or less. This is when the central chemoreceptors are activated. So regardless of whatever the etiology, whatever the reason, a patient's PaO2 drops to 60 or less, the central chemoreceptors, they're still there, but they bow out. Oh, it's another need here. I know when to be quiet. And they allow the peripheral chemoreceptors to step up to the plate. And the peripheral chemoreceptors will then begin to control how a patient breathes. But now let's look at this. I told you the PO2 is less than 60. So what is, if a patient has a PO2 of 60, what is that telling you from a blood gas perspective? They're hypoxemic, right? Okay. So peripheral chemoreceptors is also called the hypoxic drive. That's what I have on your slide. If PaO2 is 60 millimeters of mercury or less, then a patient is breathing off her hypoxic drive. I'm reading it directly from your PowerPoint. Okay? Make sense? And that's how they're going to breathe. They're going to breathe off their hypoxic drive. We give them supplemental oxygen. Person's got pneumonia. Doctor has prescribed some antibiotics, yes, to fight the infection. We give them supplemental oxygen. As that pneumonia is resolved, and we give supplemental oxygen, we do a blood gas maybe 8 hours later, and the PO2 is 68. Are they breathing off their hypoxic drive now? No. Because the peripheral chemoreceptors only kick in when a patient has a PO2 of 60. So if the PO2 drops to 60, then the peripheral chemoreceptors will kick in and the central chemoreceptors will lie dormant. But once that PO2 is raised above 60, it don't have to be 80 to 100. It doesn't have to be normal. It's just above 60. In our case that I gave you, it went from 60 to 68. And the next day, it went from 68 to 72. The peripheral chemoreceptors shut down, and now the patient is breathing again off their central chemoreceptors. Any questions? So if a person has a PO2 less than 60, what's stimulating them to breathe? You're going to tell me one or two answers: peripheral chemoreceptors or hypoxic drive. And when you say hypoxic drive, you need to be able to tell anybody what that means. A PO2 of 60 or less. A patient breathes off their hypoxic drive. So respiratory therapists understand how a patient breathes. It's so much more than a rate to 12 to 20. It begins there, but it's so much more. Any questions? Okay. So you got a patient that has a PO2 of, let's say, 70. Are they experiencing hypoxemia? Yes. Because it's less than normal. It's less than 80. But are they breathing off their peripheral chemoreceptors? No. You got a patient who has a PO2 of 48. Are they experiencing hypoxemia? Yes. Are they breathing off their hypoxic drive? Yes. How do I know that? The PO2 is less than 60. Right? Any questions? All right. Now, when this PO2 becomes 60 or less, things begin to happen in the body. Okay, things begin to happen. Look at the same PowerPoint. I don't know what number it is, but it says central chemoreceptors and peripheral chemoreceptors. The last bullet, it says clinical physiological manifestations. Everybody see that? Mm-hmm. All right. When the PO2 hits 60 or less, the first thing that's going to happen is the heart rate increases. And when the heart rate increases, what is that? Sympathetic or parasympathetic? Sympathetic. Anytime a patient has a PO2 less than 60, you will probably see them tachycardic. And I want you to understand why. It's nothing we can do about it. Physiologically, it's happening. Somebody tell me, why in the world would the heart rate increase?
Put more oxygen into the system.
For internal respiration. The heart says, uh-oh, it's a problem here. I got to straighten up my game. And so the heart will begin to pump out more blood for cardiac output, for internal respiration. Does that make sense? Mm-hmm. I'm going to ask you over and over and over and over again. Okay? So the first compensatory response when the PO2 hits 60, meaning that a patient is breathing off their peripheral chemoreceptors, this is what happens. The heart rate increases. That's the first thing. What's the second thing on that same PowerPoint slide? Respiratory rate increases. Tachypnea. Why?
To get more oxygen.
To try to take care of external respiration. The heart rate is first. Try to take care of internal respiration. Why do you think the heart would kick in before the respiratory rate kicks in?
Wouldn't they be able to need, so to speak, your muscles before they go away?
But why? You're right, but why?
Because the heart, well, it's 98% of oxygen.
There you go. You get the keys to the car, because 98% of oxygen carried through our body is through cardiac outputs. And the heart wants to do its responsibility. It wants to be responsible. So the first compensatory response to a PO2 of less than 60 is the heart rate goes up for internal respiration. The second response is tachypnea for external respiration. Does that make sense? And I'm going to ask, and you got to know them in this order. I expect you to know them in this order. All right, what's the third? Third says pulmonary vasoconstriction. Can we see pulmonary vasoconstriction? No. But somebody asked me last week, I don't know what the question was, but I wrote it up here, pulmonary hypertension. You all remember me writing that? That's pulmonary vasoconstriction. That pulmonary trunk, the pulmonary arteries constrict, means it's trying to pump the blood through the pulmonary trunk harder. Anytime a patient has pulmonary hypertension, what did I tell you? You know. They are what? Hypoxemic. I'm not even giving you any numbers. These are numbers. You'll learn the second year in hemodynamics. That's what second year students are doing now. But anytime a patient has a PO2 of less than 60, their pulmonary arteries will constrict. Will you see that? No. It's physiologically going on. Okay, but you won't see it. That's what happens. And anytime you see pulmonary hypertension, you know that a patient is hypoxemic, whether you have a PO2 or not. Doesn't matter. Any questions with that? And what does the fourth one say on your PowerPoint? What does diaphoresis mean? What does it mean? What's the patient doing? They're breaking out in the sweat. Why are they breaking out in the sweat? Could be SNS response, or it could be what? No, not shock yet, not yet. Why do they break out? Why do you think you all said cold and clammy?
Because their body's working harder.
Their body is working harder to do what?
Get rid of that CO2.
Get the oxygen.
No, they're breathing off their hypoxic drive. Because what?
To get the oxygen.
To get the oxygen to the tissues. That's it. You get the second set of keys to the car.
So the body, you're breaking out the sweat, and that's doing what for you?
It's working harder to get the oxygen to the tissues. And some of you said cold and clammy. What's going to be cold?
Skin.
Your skin.
What part of your skin? Hands and what else?
Face.
Face.
Face. Why?
There's more sweat glands.
No.
Looking at the-
What's going to be warm? What's priority
Oh,
now?
the central core.
Central core.
Core.
What's going to happen is your body is going to make a decision and send the oxygenated blood to core organs, major organs. Okay? Therefore, extremities, toes and fingers may be deprived because it's not important. That's when you may see cyanosis. Okay? Because fingers and toes didn't get the oxygen, but it was more important that the brain got oxygen, the stomach got oxygen, the kidneys got the oxygen, the pancreas got the oxygen. And so now, when you go to the hospital and you see accessory muscle use, you see the patient is short of breath, you see the patient is sitting up on the side of the bed and they can't lie down, they can't sleep, you see them broken out in the sweat, you won't panic because you'll understand, even without seeing a PO2, that they're breathing off their peripheral chemoreceptors. And they're going to continue to manifest these things until oxygen either resolves the problem or whatever the underlying problem is. So you're going to see these manifestations. You won't see the pulmonary hypertension, the pulmonary vasoconstriction, but you're going to know that it's there. Anytime a PO2 is less than 60, pulmonary arteries constrict to try to pump the blood or force the blood through the pulmonary trunk to get to the capillaries for gas exchange, hopefully, but that's not the answer. And this is called compensatory mechanisms whenever a PO2 becomes 60 or less, and there's nothing we can do about it. But I don't want you to freak out. So if you have a patient and their PO2 is 58 and you see their heart rate is 147, you don't recommend a beta blocker. The issue is not the heart. The heart is increased because the patient's PO2 is less than 60. Give them the oxygen that they need. When the PO2 becomes greater than 60, you'll see the heart rate subside. You'll see their respiratory rate subside, and you'll see less accessory muscle use. And you may see blue turn back to pink. Make sense? That's why we give oxygen. But again, oxygen is not necessarily the answer to every problem. Yes.
So my question is, if a patient's cold and clammy, does that always mean?
No, ma'am.
they're-
No, ma'am. No, ma'am. I'm talking about when a PO2 is less than 60. No.
Yeah, I just wasn't sure if
No,
every
ma'am.
time it's less than 60. they'll
Nope.
cold and clammy.
Nope.
Okay.
Good question, but no.
Okay.
Okay, any other questions? All right, now you know about the hypoxic drive, peripheral chemoreceptors. If the PO2 is greater than 60, we're still breathing off our central chemoreceptors. And whenever the PO2 drops less than 60 or 60 or less, then we kick over to our peripheral chemoreceptors. Once that problem has been resolved, the PaO2 may not necessarily have to go to 80 to 100, but it gets higher than 60s. The peripheral chemoreceptors will shut down. Those 4 responses will stop. And then again, that patient is breathing off their central chemoreceptors. Therapists understand this. This is just not for a test. And I know it's going to take time. Yes.
How fast does it typically happen if you saw somebody with a PaO2 of, say, in their 40s?
They probably need mechanical ventilation unless I know what the etiology is. Tell me an etiology and then I can tell you what we can do for them.
Let's say it's not so serious. Let's say it's in the 60s, or let's say it's 58, and you start feeding them oxygen. How soon would you see all?
Depending on the etiology. What's the cause? I need to know a cause. Are they chronically hypoxemic? What caused it? You always have to look at a cause.
So the cause would determine how fast their body would process what you're giving them.
Yep.
So if it's COPD, it would be extremely slow. You may not see a reaction real
If it's
quick.
COPD, you might not see it change 20, 30 minutes.
But carbon dioxide poisoning, you would see almost
Carbon monoxide
monoxide
poisoning?
rather. You would see a pretty quick change, wouldn't you?
It depends on how you get the oxygen to them. If you put them on a mechanical ventilator, it may take an hour or so. If you put them in hyperbaric therapy, it depends on how you're going to administer the oxygen, what kind of change you're going to see. If you don't have hyperbaric therapy, you're going to give them a non-rebreather, 15 liters per minute. Depends. It depends. Again, etiology will determine. Underlying cause, I'll put it that way.
Okay.
Okay? So that's what happens if you and I get a PO2 of less than 60. Yes.
Something that just reminded me, a friend of mine had to go through hyperbaric treatment, and something about it made her vision go, her vision got worse while she was going through the treatment. So
That's one of the side effects, unfortunately.
And then that's from, is that oxygen toxicity?
Yes, ma'am. Unfortunately. Probably wasn't the best choice for her. After the fact, yeah. Okay, any other questions? All right, now, I have not talked about COPD. Here we go. Chronic obstructive pulmonary disease. There's always an exception to the rule. And then after this, I'm going to stop so we can go through the exam. COPD, chronic obstructive pulmonary disease. First of all, any patient that is diagnosed having an obstructive disease, when respiratory therapists, when we look at conditions, is it a problem on inspiration or is it a problem on expiration? Is it a problem of the upper airway, lower airway, or the thoracic cavity? Asthma and COPD are obstructive diseases, meaning the patient has a difficult time exhaling. The patient has a difficult time exhaling. Obstructive diseases mean the patient has a difficult time exhaling. And just for your information, I'm not going to test you on it. If a person has a restrictive disease, they have a problem inhaling. But I'm speaking solely obstructive. So asthmatics and COPD patients, they don't have a difficult time initially inhaling. They have a problem exhaling. And that's bad because exhaling or exhalation is passive. It's bad. It's passive. But what happens is because of their condition, they can get the air in, but it remains in their lungs, and we call it air trapping. And they can't exhale it. They can't exhale. They can't adequately exhale like they should. So to tell them to blow out a birthday candle might really kill them, literally kill them. They can't do those kind of things. Does that make sense? Everybody with me? All right. So obstructive diseases have a problem exhaling. All right. So let's go back to the COPD patient. They've got this stale air stuck in their lungs, and they can't exhale it, right? What is the purpose of exhaling?
Get rid of CO2.
To get rid of CO2. Now, they can't exhale, right? So this stale air continuously remains in their lungs as air trapping, right? All right. Now, the central chemoreceptors, the hydrogen ion, is steadily telling the lungs, okay, work harder, blow the CO2 off. But because the condition is chronic, and by definition, Rachel told us it's a condition that takes over a period of time, and COPD surely takes over 90 days. It may take years to happen. But COPD is a combination of two conditions. Right now I'm not going to give you the conditions. But they retain stale air. So if they're retaining air, their PCO2 is going to continuously stay up, right? And what do we call that from an acid-base determination? Increased PaCO2. Acid. What kind of acid?
Respiratory.
Respiratory acidosis. So you've learned. COPD patients have a problem exhaling. They have air trapping, meaning this air stuck in their lungs and they can't exhale it. And therefore, the PCO2 stays up, right? And they're always in respiratory acidosis. Okay. So now we got these central chemoreceptors steadily trying to send messages to the lung. Blow off. Blow this CO2 off. Blow this CO2 off. But the lungs can't. The lungs can't because of the air traffic. Okay, and I'm going to make the situation worse. A person's been diagnosed with COPD. The doctor, the therapist, everybody says you need to quit smoking. They choose to continue. So the smoking is not helping their condition. And every time they try to exhale, they can't. So when they try to exhale and they are not successful, they're retaining more CO2. So the more CO2 they retain, the more respiratory acidosis insists, right? Now, central chemoreceptors have continuously sent messages to the lungs that say to blow off this CO2. And the lungs aren't capable. So what happens? The central chemoreceptors get tired. Say, okay, now I've told you and told you and told you. I tried to show you. I tried to encourage you. You won't listen. So central chemoreceptors in COPD will shut down. And once they shut down, this process is irreversible, meaning never, ever again will they be activated. I'll give you time to write. This is only in COPD. Central chemoreceptors shut down. Hydrogen ion no longer responds. I've done everything for you. Everything I could for you. But you're on your own. So what do they have left now? Peripheral chemoreceptors or hypoxic drive. Right?
Yeah.
All right. That's all they have. But what have you learned about the hypoxic drive? When is it activated? PO2 is 60. So what happens? If you give a COPD patient or a CO2 retainer too much oxygen, listen to me well. If you give them too much oxygen, you knock out their hypoxic drive and they die on you. Because that's all they have. So CO2 retainers, you cannot give them too much oxygen. CO2 retainers, you can't give them 100% oxygen because you're going to kill them.
So the peripheral is like their last chance.
That's it. They breathe off their hypoxic drive. They're chronically hypoxemic till the day they die. And the more they smoke, the worse it gets. So we can give them a little bit of oxygen, but we can't give them a whole lot. Yes, ma'am.
So once COPD is determined?
CO2 retainer.
Okay.
Once a CO2 retainer is determined.
Okay.
Yeah. And let me clarify, not all COPD patients breathe off their hypoxic drive. But if they've been determined to be a CO2 retainer, that means their central chemoreceptors have been knocked out, and all they have are their peripheral chemoreceptors. So we have to be very, very careful about how much oxygen we administer to them, because we'll knock out the hypoxic drive. They will go apneic on us, and we kill them. Everybody got that? Yes, ma'am, you had your hand up.
So it's always going to be like a low flow or a minimum amount of oxygen?
Always.
Okay.
Always.
So it's always going to be a minimum percentage in the amount of oxygen you're
Always.
getting.
Always. We don't want to give them 50, 60, 80, 100% oxygen unless they're on a mechanical ventilator and we're controlling everything. But we can't give them high concentrations of oxygen. We cannot. We will knock out their hypoxic drive and cause them to go apneic. Now, a therapist knows this. Maybe the doctor might be a pulmonary fellow, pulmonary resident, Lord forbid, whatever. And they say, give the patient a non-rebreathing mask at 10 liters per minute. And we know they're CO2 retainers. You better not. You better talk to that physician. And that's why I was saying, if you're shy, you're timid, this is not the profession for you, because you're your patient's advocate. They may not know they have a hypoxic drive. You got to speak up. No, I can't do this. I'm going to knock out the hypoxic drive. Well, what's a hypoxic drive? Shame on them if they don't know it, but you got to be able to articulate and tell them, I can't do this. We're going to knock out the patient's hypoxic drive. So you need to know that just like you know your address. What is a hypoxic drive? What are central chemoreceptors? What are peripheral chemoreceptors? Tie that into oxygenation and tie it into acid-base balance. Yes.
So we find that a person is a CO2 retainer by taking a blood gas. With
Yes.
pH being...
And then unfortunately there's a term I hear students use and therapists, frequent flyers. I hate that term, but nevertheless they're always there. And some of them you'll get to know. You'll know the family, you'll know the wife, the husband, the children, the grandchildren, the neighbors, and the pastor.
And that's considered hypoventilation.
It's considered hypoventilation, but it's chronic hypoventilation, and that's all they have.
And that's what COPD is, chronic hypoventilation.
No, COPD is chronic obstructive pulmonary disease, but there's a classification of those patients that become CO2 retainers. And they're the ones that no longer have their central chemoreceptors, and all they have are the peripheral chemoreceptors.
And that's considered chronic.
Right. And so what am I saying? Two things. They're always in respiratory acidosis, and they're always chronically hypoxic. They will never, ever have a normal PO2. And if you try to give them one, you're going to kill them. They can't have a PO2 of 80.
So when they do get classified as a CO2 retainer, that's at a certain point in the COPD process?
Pulmonologists will make that call.
And they want, you're,
Okay.
they're, that's what that was.
Pulmonologists will make that call. But you'll know it. You'll know it. It's stage 1, 2, 3, and 4 of COPD. Stage 1 and 2, well, obviously 2 is worse than 1. Stage 1 and 2, probably not CO2 retainers. Stage 3 and 4, they are. They are. And stage 4 is terminal. And yeah, we give them oxygen supplementally, but it's not doing anything.
So to cure COPD, they'd have to find a way to stimulate the central chemo.
There is no cure. It's a terminal, degenerative, slow, debilitating disease. It is no cure.
So the ones that keep smoking, not only are they retaining that CO2, but they're retaining the carbon monoxide and all the other carcinogens are in their lungs. That's bad.
And most COPD patients die with COPD, but they die from heart failure because it overworks the myocardium. Yes.
So, say stage 1 COPD, before their chemoreceptors stop working altogether, say they correct the smoking or maybe whatever, is there
The
a
damage
chance
that's
to-
done is done, but it doesn't have to continue to ensue. So any damage done from any lung disease is done, because once the alveoli or the integrity of the alveolar capillary membrane is altered, it's altered. But we can stop it here if an individual will stop smoking. 90% of COPD is caused by cigarette smoking. Now there is a group where it's autorecessive gene. They don't have to smoke. It's because of chromosomes. But 90% of COPD is from cigarette smoking. And the damage done is done. It is irreversible.
So you could stay at stage 1.
Yeah, you could stay at stage 1, but it's going to be some struggle. You may not be a CO2 retainer, but you'll be okay. Yeah.
So you're just wearing out that heart. It's just...
Ultimately, it wears out the heart. Just like people with AIDS don't die from AIDS. They die with AIDS. But they die because of the compromised immunosuppressed system, and they die from off-the-wall infection. So COPD patients generally don't die from the lung disease. They die from heart failure. Because as you deprive the lungs of oxygen, you're also depriving the heart. And they quite typically die from congestive heart failure. Quite typically. Okay, any questions? We've gone through a lot, but this is oxygenation. So you've learned about the indications for oxygen therapy. You've learned about peripheral chemoreceptors, which is also referred to as the hypoxic drive, a PO2 of 60 or less. If the person is not a CO2 retainer, once that low PO2 is corrected, we go back to breathing off our central chemoreceptors. However, COPD patients who continue to smoke don't have that option, And so their central chemoreceptors are shut down, irreversible damage is done. And so all they have is their hypoxic drive. So we can't give them too much oxygen because we'll knock out that hypoxic drive. They will hypoventilate and consequently have a respiratory arrest. Any questions? Yes.
For the COPD that's chromosome, that's affected by that, is that hereditary?
Yeah. Yeah, that's hereditary. Yeah. Any other questions?
So COPD patients always have a oxygen less than 60 or?
No, not all, just the CO2 retainers. It's stage 1, stage 2, stage 3, and stage 4. I'm talking about stage 3 and 4. It's gotten worse, probably, and not judged, but just based on data, probably because they continue to smoke. Okay? It's slow, it's debilitating, it is a horrible condition. But some people will smoke till the day they die. It's their choice. All right, Maria, we're going to go through the exam very quickly.